Good day, everyone. My name is Crystal Anderson, and I'm the Director of Clinical Informatics here at HIMSS, and I'm pleased to welcome you to our third and final installment of the Pharmacy Town Hall Series, which is brought to you by HIMSS, NCPDP, and Surescripts. In our first Town Hall Series, we learned a little bit about E-Prescribing. Our second one focused on medication history. And today, our third and final, will focus on the new standard for electronic prior authorization. Today's Town Hall will focus, and if I could ask technically that the slide go back to the previous slide, thank you. Today's Town Hall will focus on the following objectives. Our speakers will explore prior authorization challenges and new electronic solutions in order to learn about the value made possible by EPA. We'll also be exploring the script standard for EPA. We'll also explore some opportunities of how EHR networks, EHRs, and PBMs are implementing the new script standard. And lastly, our speakers will cover how gaps in care can be addressed by real-time integrated electronic prior authorization and how you can accelerate adoption. Now I'd like to tell you a little bit about NCPDP, who serves as our collaborator for the Pharmacy Town Hall Series. NCPDP, or the National Council for Prescription Drug Programs, was founded in 1977. They are a non-for-profit, ANSI-accredited SDO organization with over 1,600 members representing virtually every sector of the pharmacy services industry. NCPDP members have created standards such as the telecommunications standard and batch standard, the script standard for e-prescribing, and the manufacturer's rebate standard, and many more to improve communication with the pharmacy industry. You can learn more about these activities and several others by visiting their website at www.ncpdp.org. Our sponsor for the Pharmacy Town Hall Series is Surescripts. Formed in 2001, Surescripts has evolved into the nation's most comprehensive clinical network. Surescripts connects pharmacies, payers, pharmacy benefit managers, physicians, clinicians, hospitals, integrated delivery networks, health information exchanges, and health technology firms to enable the efficient and secure exchange of health information. With over 500,000 prescribers and 600 EHR applications, and 94% of community pharmacists are active on the Surescripts network. You can learn more information about Surescripts by visiting their website at www.surescripts.com and by following them on Twitter at twitter.com/Surescripts. HIMSS also serves as a collaborator for the Pharmacy Town Hall Series, and again, thank you to NCPDP and Surescripts. HIMSS is a global, cause-based, not-for-profit organization focused on better health through information technology. We lead efforts to optimize health engagements and care outcomes using IT. You can learn more about HIMSS by visiting www.hims.org and also by exploring many of our pharmacy informatics resources. Later in today's presentation, we'll be providing you with information about pharmacy informatics, including the slide and recording information for today's town hall. Now I'd like to introduce today's speaker. Our first speaker is Dr. Anita Mirko. She serves as President and CEO of Health Consultancy Cambria and a clinical associate professor with 25 years of practicing experience as an internal medicine physician. She has been formative in Arizona's Health Information Exchange, E-Prescribing, and EHR initiatives. She is a recent recipient of the American College of Physicians Laureate Award, the Arizona Capital Times Leader of the Year in Public Policy for Healthcare, and was selected by the Arizona Business Magazine as a Healthcare Leader of the Year and Public Policy finalist. Dr. Mirko received her MD from the University of Pittsburgh School of Medicine and completed her internal medicine residency at Indiana University. And we're very excited to have her as a HIMSS member. Our second speaker will be Melissa Brown, who serves as the product director at Surescripts for benefits messaging. She is responsible for electronic prior authorization and other product offerings that leverage NCPDP standards. Melissa is an active member of NCPDP and has more than 19 years of experience with the development, launch, and implementation of healthcare IT products and services. She has a Bachelor of Science degree from the University of Wisconsin. And with that, I will turn the presentation over to Dr. Mirko. Thank you.
Thank you, Crystal. Good morning or afternoon, everyone. I can say that I'm very pleased to be part of the discussion today about this exciting new standard and great new tool for healthcare delivery. In the provider and prescriber world where I spent most of my career, prior authorization is almost a dirty word, and it conjures up the unpleasant process that currently is a hodgepodge of the forms, faxes, phone calls, and standalone portals that we're going to talk about in this first segment of the presentation. Next slide. So when prior authorization started about 25 years ago, which is when I started practicing, it was basically an innocuous and important process to manage the cost and improve the safety for medications. Over these past 25 years, though, it has really mushroomed into today's not-so-pretty reality. Part of the reason is because every plan, and now there are more of them, has its own forms and formats for specific drugs and drug classes. These are updated at least quarterly and sometimes as often as monthly. It's okay if you have just a few health plans that you work with, but the average primary care office works with between 20 and 50 plans, and during our tenure in practice, we worked at one point with 100 health plans, and so that can become extremely unwieldy when each of them has their own form and format. Additionally, over the interval between 2005 and 2010, the actual number of prior authorizations has increased sixfold, and this is according to a study that was published in 2011 by the Center for Healthcare Transformation. If I put on my health plan hat, I can rationalize these increases in the number because of the increase in the number of specialty drugs, biologics, advances in medication therapy management. But next slide. As a provider, the current non-system of prior authorization really significantly impacts the quality of care and adds to the cost. The quote here in the center of the slide is from Dr. Ellis in an article that was published just a few months ago in Medical Economics, focusing on the hassles of prior authorization. And Dr. Ellis sums up pretty well the general provider sentiment around prior authorization in that it's a nuisance, it's time-consuming, and very frequently it's not in the best interest of the patient. Next slide. The pain of prior authorization really does impact everyone. And I'm going to just take a couple of minutes here and walk through the process, starting on the left side of your screen with the provider, who is writing and or hopefully e-prescribing and transmitting a prescription to the pharmacy. At the top of the screen, you see the pharmacist who is attempting to process the prescription and then discovers that a prior authorization is needed. The pharmacist then needs to communicate that delay to both the patient and the prescriber using generally a phone and or fax. When that denial requiring prior authorization hits the provider office, that sets in motion a whole set of steps between the provider and the PBM. And that generally involves the combination of communications between the fax, the phone, and sometimes the standalone portal. When the appropriate information does make it in the appropriate manner to the PBM, which is identified in the top right hand of your screen, then the information is transmitted to the provider and eventually to the patient. Regardless of the outcome, whether it's approved or denied, it's disappointing that the person that we're trying to help is generally frustrated or worse, regardless of the outcome of the actual process. Next slide. The current process does have some pretty significant burdens, and they are measurable in some ways. Health Affairs devoted an entire issue in 2009 on the administrative cost to the United States healthcare system. And in this particular article, they identified that on average, physicians spent more time dealing with drug prior authorizations and formulary issues than any other health plan interaction. Next slide. Overall, interactions with health plans were estimated to cost between $23 and $31 billion a year, and specifically in the realm of the prior authorization, depending upon the specialty, location, configuration of the practice, physicians were spending between 3 and 8 hours per week on activities related to the prior authorization of medication. And when you add on the time spent by staff, by medical assistants and nurses at the particular provider offices, you end up with thousands of dollars per year that the prior authorization system exacts from the provider and practice community. Next slide. And because the pain is felt everywhere, the prior authorization also has a resource-intensive impact on the PBMs. About 90% of the PA requests require some sort of communication between the prescriber and the PBM by phone or fax or by portal now. This runs between $20 and $25 per submission to the PBM, and it may come as a surprise to some providers that the PBMs and payers are concerned that there are so many physicians frustrated with the process of prior authorization and actually call it physician abrasion. They are concerned that the physician abrasion and patient complaints will damage their reputation. So it is a burdensome and costly process for PBMs as well. Next slide. In the pharmacy arena, the pharmacists devote a significant amount of funds as well as time in processing the prior authorized prescriptions per week. And in this study, a full-time pharmacist processes about 1,400 prescriptions per week that require prior authorization. Next slide. The prior authorization process has the most significant impact on our patients. And you can see the patient here describing the experience that they recently had with a presumably simple change of a medication dosage from 2 to 4 milligrams. The patient, however, found out that the script required a prior authorization, and like happens in many cases, the patient was out of meds. Patient then has to decide if they will go without their medicines, if they will pay out of pocket, if they can afford it, if they need to seek an alternative, or at some point decide about launching an appeal in coordination with their provider. Even in the best of all worlds, the prior authorization process for an approved medication in the vast majority of cases takes 2 business days or more. So we have a pretty significant gap in care from the patient standpoint. Next slide. So it's probably not a great surprise to you to learn that prior authorization is a top priority for providers. There are a number of studies reported here, and in summary, it is the number one desired e-prescribing capability. That providers are very frustrated with prior authorization, and almost a third would switch their electronic health record vendor if they could have electronic prior authorization as an integrated solution with their vendor. Next slide. So to discuss how we can actually make this happen, Melissa Brown from Surescripts is going to tell us about the details about electronic prior authorization using the new standard. Melissa.
Thank you. Well, good morning and afternoon, everyone. First, I'd like to thank you, Dr. Merkel, for providing us with insight into the current PA process and highlighting some of the challenges and frustrations that currently exist. At Surescripts, we've been involved with a number of initiatives to help bring forward an electronic prior authorization solution, including the development of our own product that is based on the new NCPDP EPA messages. So I am really excited to be here today to help share information about the new NCPDP EPA messages and to talk about how we can all work together to address some of these challenges and complexities that Dr. Merkel had highlighted during her portion of the presentation today. Next slide. So over the past decade, as we all know, e-prescribing has been improving and evolving through the use of the NCPDP script standards. In July of 2013, the NCPDP script standard approved the addition of new messages to support electronic prior authorization. These new transaction sets will support an electronic prior authorization workflow that will exist between the prescriber and the payer for the exchange of this valuable information. Next slide. With the availability of these new EPA message types, the current PA process can now be automated and streamlined into the EHR. The need for the paper forms, faxing, and all of the administrative overhead and delays that Dr. Merkel highlighted previously will be greatly reduced. In addition to the reduction in administrative overhead, workflow efficiencies, however, will be greatly improved. And this improvement will be realized for all of the stakeholders across the continuum of care, including the prescriber, the PBM payer, the pharmacy, and most importantly, the patient. Next slide. So in 2012, Caremark had led an EPA pilot, and they were joined by a number of the key stakeholders that we've highlighted here. This pilot was extremely valuable toward the development of the newly approved NCPDP EPA messages. Through this pilot, we were able to learn a lot. It confirmed that an electronic solution could be implemented, information could be exchanged real-time between the prescriber and the payer, and the EPA process could be implemented successfully into an e-prescribing workflow. In addition to these learnings, we are also able to take information to help further define and that work towards the development of the NCPDP standard. Next slide. So through the development of the new EPA standard, the ability to implement a prospective EPA as part of the e-prescribing workflow is supported. And the prospective workflow is one in which the prescriber is able to handle the PA process up front during the e-prescribing process. And this is prior to the prescription being sent to the pharmacy. The ability to address a prior authorization prior to the prescription arriving at the pharmacy is truly seen as a best practice for e-prescribing. I should note that the NCPDP standard also supports a retrospective workflow as well, and this is where the prescriber initiates the PA after the prescription has been rejected. And from our experience within the Surescripts implementation, our plans are to support both a prospective and retrospective workflow The reason being that while we realize that a prospective solution is ideal, we also realize the fact that there will be situations and occurrences where the physician will need the ability to submit an electronic prior authorization after the prescription has arrived at the pharmacy. Next slide. So now that I've introduced the concept of a prospective EPA inside of the e-prescribing workflow, I'd just like to take a few minutes and walk you through a high-level workflow to show how this would be implemented, and I'm referencing how we've done this at Surescripts. Other implementations could vary, of course. So if you look at the two arrows across the top, this represents the direct connection between the prescriber and the payer, which is used to handle the EPA process that takes place prior to the prescription being sent to the pharmacy. And then if you look at the arrows to the left, this represents the submission of a prescription that has gone through the PA process in advance of the prescription being sent to the pharmacy. And then finally, if you look at the patient in the bottom right-hand corner, the end result is a script arrives at the pharmacy and the patient is able to get the drug that they need without delay. Next slide. So as I just walked you through the high-level workflow on the previous slide, I briefly touched on some of the key features of the EPA workflow. It's providing information up front and handling it before the prescription arrives at the pharmacy. But I wanted to take a little bit of time on this slide to focus on some of the other key features of an EPA solution that's integrated into the EHR. One feature is that because it's part of the e-prescribing process, the eligibility and formulary data that's used for e-prescribing is also leveraged to help support the prior authorization process, because the physician can be notified that a particular medication requires a prior authorization before they start the e-prescribing process. And another key feature is that through the electronic exchange of information, forms are completely eliminated, and the specific PA questions that are needed for the PA approval process are sent to the EHR. They're patient plan and medication specific, and they're provided to the prescriber in a real-time fashion through the support of the standards. And also one other key feature is because it is tightly integrated into the EHR and part of the prescribing process, a lot of the required patient information that currently requires the manual entry of information will be eliminated, and some of that information can be pre-populated. And this creates a great efficiency, accuracy, and reduces a lot of the administrative tasks that are associated with the prior authorization process today. And then finally, because the prior authorization is handled up front, the prescription arrives at the pharmacy and they're not subject to dealing with the PA process on the back end. Next slide. So this is a list of all of the message types that the standard supports, and they make up they support a full range of the EPA process. The range of messages support the ability to initiate a prior authorization electronically all the way through the support of the appeals process. Next slide. So during today's presentation, I've provided information that highlights a fully integrated EPA implementation that supports the full range of features that can be leveraged through full EDI exchange that is supported by the standard, noting that these features and functions may vary by each company's implementation. So from here, I'm going to hand the presentation back to Dr. Mirko, who will walk you through what an implementation would look like when an EPA has been fully integrated into the EHR and the prior authorization is being handled prospectively inside of the e-prescribe workflow. Thank you. Dr. Mirko?
Thanks, Melissa. We will now move to the next slide and embark upon our journey into the world of integrated electronic prior authorization. As Melissa mentioned, one of the most important and most exciting features is that the prior authorizations are able to be implemented during the EMR workflow, during the process of e-prescribing, so that as you are prescribing, you know that a prior authorization is required. So we start with the initiation of a prescription, in this case for Crestor. Next slide. With the internal integrated knowledge that Crestor requires prior authorization, the PBM question sets are delivered directly to the electronic medical record through the e-prescribing module, and start out with asking what strength of the drug is being requested. With this question answered, and we'll go to the next slide, the series of PA questions are then presented to the prescriber in a logical, sequential, and hopefully non-repetitive flow. Next slide. Because skip logic is used, the most relevant questions are the only ones that will be displayed, and the total number of questions are minimized based on using the answers from the prior questions. One of the, I think, differentiators of products as we innovate in this space is that in addition to incorporating simply the answers to the questions, we can more deeply embed this in the electronic health record database and make use of much more of the information in the record, and perhaps even use natural language processing to handle some of these queries. Next slide. When all of the questions are appropriately addressed, the full panel of questions is provided for the provider to review before hitting the submit button. Next slide. Once the submit button is pressed, the information is transmitted to the PBM, and in seconds or minutes at the most, if we rely upon the demo that was recently mentioned by Melissa, the information regarding an approved prior authorization can be transmitted in real time to the provider. Next slide. Depending upon how this is implemented and configured in the electronic health record, this information can be displayed in the e-prescribing module and in the task list or other areas in the record, and can be used to transmit to notifications of the pharmacist and or the patient about the prior authorization. So this is very, very exciting to know that this can be embedded in the workflow and is right now happening in pockets across the United States. Next slide. So where are we today? We had a successful demo. NCPDP has been working with stakeholders on the standard for over 18 years. And now we are seeing adoption and implementation in these pockets around the country. Next slide. Right now, there are 8 states that mandate some type of electronic prior authorization for medications. And some of these statutes in the states that are listed in the dark navy blue on your screen actually call out the NCPDP script standard for EPA. There are a number of other states that are working specifically around administrative simplification efforts at the state level and are requiring standard forms of prior authorization for procedures, services, as well as medications. And in most of the other states, there is some level of activity and interest around draft legislation or studying how electronic prior authorization, and specifically electronic prior authorization for medications, can be implemented. Next slide. The efforts are being spearheaded by a multi-stakeholder group. And as we mentioned, NCPDP, with its long history in identifying and perfecting the standard, is in the lead. There are also other standards bodies, regulatory agencies, and government involved, as well as leaders from all parts of industry, including the PBMs, electronic health records, those involved in the pilot, and other health information technology networks that are required to support and maintain the EPA features that will be available to more and more across the United States. Next slide. So what can you do to accelerate the adoption of EPA and improve healthcare delivery in the amazing ways that you can just imagine based on the problems that we're having with our current system? One of the things is you're with us today and you're learning about the new script standard for EPA, and we'd like you to share this with others and spread the awareness about how the standard can be used, implemented, and its potential value. It's great to have a standard, but it's only as good as it is implemented in a collaborative environment. The next step for you might be to learn more details about EPA, and some starter areas include the NCPDP website, Surescripts website at Complete EPA, includes a kind of a fast starter module that you may be interested in. And there's a great deal of information at the Caremark website based on the information that they learned in being involved in this pilot for the last 2 years. It's also going to be important that after you learn about and are comfortable with the standard and the way it can be implemented in your organization, that you put it on your roadmap, that you prioritize its use, that you include it in your RFPs and make use of it in your planning processes, whether you're an electronic health record, whether you use an electronic health record, health plan PBM, or pharmacy information network. As you've noted, our legislators are very much interested and involved in simplifying and streamlining the healthcare delivery system. And it's going to be up to us to educate our legislators about the standards, how best to apply it so that it works to improve care opportunities for ourselves, our patients, our families, and everyone who counts on and depends upon us to deliver health care. Next slide. So, in summary, the integrated script standard for electronic prior authorization is another very important, very exciting step towards the triple aim of better care, better health, and lower costs for all Americans. I thank you for your attention, and this is the close of the formal part of this presentation.
Thank you so much, Dr. Merkel and Melissa, for presenting. Now we have a series of questions that have come through, and for all of our 300-plus attendees, please feel free to use the Q&A panel, which is located on the right-hand side of your screen, and submit your question electronically. I will queue them up for the speakers. The first question that we had, and I'm going to try to prioritize these and list them kind of in buckets. One of the questions that we received from our attendees are, what are some of the main reasons that payers require prior authorization for medications?
Melissa, do you want to take that one?
Sure. Well, some of the, I think it's going to vary by health plan, but each PBM or health plan works with their plan to determine which drugs need to have a prior authorization applied per that patient's benefit. And I think it varies, from plan to plan.
And so I think that some of the major focus has been on medications that are very expensive, especially the biologic medications, and making certain that they are used in the appropriate clinical circumstances. We've also learned about the importance of using the appropriate dose, appropriate length of time, and because of the managed care environment and the importance of taking responsibility for all aspects of a patient's care, the importance of understanding that the information that the patient receives and that the prescription that is given is the safest and the best for the patient in their circumstances. Guidelines change, and they are also applied within the prior authorization questions. I asked Melissa to take this question initially because as a provider, there are many questions that as I answer them, I am not excited about spending the time and energy to do it because much of the information may have been provided in the past to another PBM that wanted an authorization for this, or the only reason that we appear to be requiring this is because the payer has contracted with a different version of a generic medication or has a therapeutic substitution process. So it is more important for savings for the health plan than it is for the patient and provider who have a stable regimen that is then disrupted for the purposes of the payer. So the short answer is that there are many reasons. Some of it's cost, some of it's safety, and some of it is cost savings for the payers.
Thank you so much. And in that answer, you kind of alluded to some of the obstacles that are presented by implementing EPA. We've received a number of questions around that, and specifically, who does the transmission cost of the transaction go to? So maybe if you could talk about a little bit around the expense and any other obstacles there are when implementing this.
Sure. This is Melissa. So, the workflow that exists is between the prescriber system and the PBM health plan. And I think that, the business model is probably going to differ from organization to organization that's supporting this type of offering.
And I guess alluded also to in this question is that most of the cost will be borne by or inordinately borne by some members of the stakeholder group and not others. And I will say that that depending upon where you are in the spectrum, it's going to be work for everyone. So if you are a provider, you will need to upgrade or change your system to be able to support integrated embedded EPA, and this may require a change in vendor. The software vendors themselves, many of whom hopefully have joined us today, need to identify how they are going to embed and how deeply they're going to embed the standard and the ability to use standard scripts and questions. And PBMs will have to identify how to change their workflow process based on having this information available. So I think that it's going to be a change for all stakeholders, and it really requires a collaborative effort. And note that everyone is going to have to invest initially to reap the benefits that I think we'll be able to reap with integrated EPA.
Excellent. And you mentioned kind of the vendor's role as one of the stakeholders. We had a number of questions come out of that. Specifically, one of the questions that was raised is, how is it envisioned that EHRs will incorporate each PBM's unique questions into their software, since they vary by PBM?
And I'll say that's one of the reasons that we have invested time and energy into having a standard, and hopefully the collaborative implementation of the standard will permit streamlining that. And I will let Melissa talk a little bit more about that. And I do believe that at some point we will have an opportunity to hear more from the individuals who were involved in the 2-year pilot around their direct experience with this. But I will note that the reason why I'm with you today on this call is because I was asked to attend as a stakeholder a meeting of the NCPDP last fall, where we were talking about streamlining and improving interactions with prescribers and providers. And one of my specific complaints was this lack of ability to have electronic prior authorization. And based on that complaint, I was educated and became truly a believer in making certain that we learn to incorporate this. I spoke to some of my colleagues who were working with the electronic health record vendors, and they told me that the reason why it wasn't prioritized for them, despite their knowledge of the standard, was that providers, their customers, had not asked for it. And my response, especially based on my experience at that meeting, was we didn't know that there was something that we could ask for. And now that we know that there is a standard, we would very much like to learn from the current implementation and continue to work with the rest of the stakeholders to implement the standard in a way that is going to make the most sense for everyone, including our electronic health record vendors. Melissa, do you have any more information about the people who were in the pilot?
Sure. So one thing I just want to clarify, too, is that, in my presentation, I briefly highlighted, the various set of transactions that support the EPA standard. And within that, there is what's called the EPA initiation request that goes to the PBM or payer. And how that works is if a prior when the payer receives that request, if a prior authorization is required for that patient for that drug, one of the PA initiation response that goes back to the EHR contains the specific set of questions that are required for that patient for that drug. So that's the way in which the EHR is able to specifically render the set of questions and criteria that's needed for that particular prior authorization. And the standard does support that. And it supports the unique characteristics of each and every set of PA criteria that the PBM would require.
Thank you so much. Now, let's switch topics. We've received actually a couple of questions around this. Given that we're talking about kind of the E in EPA, and in our current electronic environment, what happens if connectivity is down during the process of submitting an EPA request?
Sure.
I guess that oh, go ahead.
Oh, I was just, because we're leveraging the standards, and the standard does support scenarios where errors do occur. So what we would expect is that we would, and I'm speaking from Surescripts, our perspective for implementation is, that we would work with the EHRs to ensure that they're setting the appropriate triggers to handle if there's any kind of connectivity issues or timeout to the endpoint to which they're trying to communicate. And it'd be very similar to how we handle prescription routing messages.
Excellent.
Yeah, so I agree, Melissa, that depending upon where you are in the chain of the process, if you are using and implementing, if you're using software, part of a good software implementation is that you have a downtime process, and so
right.
If things go down, then you have to go to that process. It doesn't happen that often, but it's an important part of asking about an e-process, and it's a very important part of planning to make sure that you have all those contingencies covered. So thank you for that very good question.
Okay, we've now received a number of questions for kind of different state levels and then also different stakeholders. So let me start maybe with long-term care. A question that we received is for long-term care where the nursing home software is the initiating source. The model described is proactive. What is the model for the retrospective where the pharmacy is the initiator to the payer/PBM?
So I want to make sure I understand the question. So when we talk about a retrospective prior authorization, essentially that's what happens today, correct? Where a pharmacy is notified that a prior authorization is required, and they pick up the phone and call the doctor who initiates the PA process. That could fully be supported in terms of the pharmacy still picking up the phone call and getting in touch with the doctor, rather than a physician needing to go into some kind of portal or them then having to pick up the phone and start the PA process manually. They can then submit that PA to a particular entity electronically versus having to follow any kind of manual process for the retrospective. The other thing in which the pharmacy could support a retrospective prior authorization is through the use of the RxChange message. Now we have some adoption issues across the industry to support RxChange or to implement that, but that is one transaction that the pharmacy could in fact utilize to message to the doctor that a prior authorization would be needed.
Thank you. Now, can we switch a little bit to some of the state perspective? We've received one question around, does the organization need to require any certification or approval from the state for EPA?
This is going to depend state by state. Right now, certification and approval for being able to make use of the standard is in the Surescripts realm, and maybe Melissa can talk about that a little bit. The states that are requiring some sort of EPA right now are just identifying their stages for implementation, and most of these are in late 2015 or 16. So the jury is out in how involved the state will be around that. Melissa, do you want to talk a little bit about certification of using the standard?
Yeah, I just wanted to echo something that, many states specifically identify the NCPDP EPA transactions as the one to use, while others identify a general electronic transactions. The expectation in the latter case is that states will use the NCPDP EPA transactions. However, I'm not aware of any states that require any particular certification that they need to go through. And then to Anita's point, Surescripts certainly does have our own set, for our implementation, set of certification requirements that we will require for our network, but they're not driven by any set of state-specific mandates.
I probably also would like to add that NCPDP has a government liaison that is extremely helpful in identifying what's happening in your state or identifying what's happening in other states that you may wish to learn about and model for your state.
And in regards to the government liaisons, could one find that information on the NCPDP website?
It is there. I can't tell you right at this moment where it is, but it is indeed there, and maybe there's an NCPDP representative on who might be able to help us with more details about that.
We'll give them 30 seconds to see if they can unmute.
I'm sorry, can you ask the question again, please?
Sure. So Dr. Mirko had suggested that people could maybe connect with some of the government relations work that NCPDP is involved in to understand how they can learn more about their own state's initiatives or even other states, what they're involved in. And then I asked where was the best place to start that journey, and we were discussing maybe looking at the NCPDP website and then seeing if a staff member from NCPDP would be able to chime in.
Okay.
Or Melissa, did you want to add anything?
No, I don't have anything to say.
Okay. So for those listening, we'll say the NCPDP website is a great place to start. Okay, so let's go back to the standard. We've received a number of questions around some of the elements that are included or not included. So the first one we received was, does the standard include structured and coded elements other than demographic? And for example, the demo showed a question about dose of the med being requested, but there would be a specific RX norm code for this med dose, and the EHR should presumably already know. So the question was, does the standard include structured coded elements other than demographic?
Yeah, the standard does support that. However, we do not expect them to be widely used.
At least in the beginning.
Right, in the beginning, correct.
Yes.
And then to go a little bit further on patient matching, what is the patient match rate to the plan to identify the PA question set?
Melissa, are you aware of this?
Sure.
Details?
So I can speak to the Surescripts implementation of how that will work. So because we'll be leveraging our eligibility transaction and our master patient index, we'll be able to identify, up front where that patient has coverage. So then we can appropriately determine where that prior authorization needs to be sent for approval.
Thank you. And then you'll have to just give me a second. They're all scrolling in so fast. Okay, let's switch to what percentage of time does the provider get a notice that a PA is required for a specific patient prior to prescribing for completing the prospective route? So what's the percentage of time?
I think that we're talking about in an integrated EPA.
Yeah, that's my understanding, Anita. I have some people here sitting with me, and we're looking up some statistics to see if we can share that, if we have that statistic.
Excellent. So we can come back to that.
Yeah, actually, okay, I have the information. So in the prospective workflow, 80 to 90% of the time when the formulary data it was 93% actually. When the data was referenced via the formulary file, it was accurate. And then in the retrospective, the accuracy was at 98%, which that shouldn't necessarily be a surprise because the claim rejected at the pharmacy, and they know that a prior authorization does in fact need to be handled.
Excellent. And thank you for digging up that statistic so fastly.
Sure.
I did want to highlight, so we did receive a plethora of information from NCPDP. Some states will be requiring that the HISP, if applicable, should be certified. Nicole Russell, RUSSEL, is the person to connect with at NCPDP. And they did agree that a great place to start around kind of what's occurring in your state is the NCPDP website. So thank you, Laura Toper and Michelle Davidson, for highlighting that for us. Okay, we did have a follow-up question regarding to long-term care retrospective follow-up. The person is asking, it would be helpful to have the stated workflow as described on this call to be included in the presentation materials, including the use of the RX change message. Do you think that would be appropriate for us to add on, or how could we share that, if applicable?
Yeah, so some of the information I was able to pull up on that is that, the long-term care model is something that is still actually being debated and refined within NCPDP to ensure that the PBMs are responding to the correct party. And the use of EPA within long-term care is being refined in Work Group 14, is my understanding, as a current status.
Excellent. Another question around the standard. Would the standard support a workflow where the provider submits the ERX to the pharmacy, knowing that it requires EPA, and then the staff completes the EPA, which follows the ERX? Do you want me to read that workflow again?
Crystal, Melissa, it sounds like it would.
Just want to let you know that we had a slight technical mishap, and Melissa is going to be right back on. Looks like she just got back on.
Yes, sorry about that.
Sorry,
so Melissa, I was saying that I thought that it would support that type of workflow, but from your standpoint, and maybe we need to repeat the question.
Yes, I'm sorry, I didn't know you had left us. So the question was, would the standard support a workflow where the provider submits the ERX to the pharmacy, knowing that it requires EPA, then staff completes EPA, which follows the ERX?
Yes, that is possible. That is possible that could occur.
And it can also be.
But I just want to clarify.
Oh, go ahead.
I just want to clarify that that could happen. However, it's preferable that that the prescription would be sent after they have the information about the prior authorization that could be included into the new RX transaction, indicating that they may have the prior auth code or prior authorization information. In the case where if they didn't want to hold it and they wanted to send the prescription through anyway, knowing that a prior authorization needed to be addressed, the standard does support the ability to message to the pharmacy in the new RX transaction that a prior authorization is in process. And I can note that for our implementation, that is something that we're, providing guidance and awareness on. And then we'll be working with pharmacy to make sure that, these are fields that currently aren't used in the new RX transaction that's part of the script standard. So we'll be working at Surescripts to make sure that information, that the pharmacies are aware that information in the new RX transaction will likely to start having information in it. We know that in talking to some pharmacies, they've indicated to us that they pull that information through, but because it's very, very rarely ever used, they're not necessarily trained to look at it. So we'll have some work there for our implementation to make sure that we're supporting and providing best practice and guidance on that.
And I'd like to add that part of the responsibility for, I think, the workflow that has been desired by the questioner is being able to order the prescription and have it in some pended environment. That pended environment doesn't necessarily have to clutter the pharmacist's desk, but can exist in the environment of the EHR while the staff is working on it until they are able to append the PA number, and it then is sent to the pharmacy. So there are a lot of ways that this can be implemented through the provider environment that doesn't require the pharmacist having to take a few extra steps, if possible, because we want to keep the noise down.
I agree completely with you, Anita.
Yeah, minimizing noise is always good. So we've received a couple of questions around medications. The first one that I'm going to queue up for you all is, how would the provider know which medications require prior authorizations? Specifically, is that information in the EMR data store kept up to date with the list of medications that require prior authorizations? And if so, how frequently is that updated?
So the big answer is yes, that as part of participating with payers that are using prior authorization, that this information would be updated on a regular basis, and that depends upon your vendor and contracts, etc. And Melissa may be able to give us some more detailed information about how they maintain this in the demonstration project and how they anticipate doing this now in the Surescripts environment. But the whole goal for the provider environment is that when you are initiating that e-prescription, that the goal of 100%, but it may be less in the beginning, is that as soon as you enter in the medication, you will know if this requires a prior authorization. As things become more sophisticated, if a certain quantity over the allotted amount may be the only thing that requires a prior authorization. And that information would, again, be available as part of the workflow. So for the provider, it should be very, very seamless if you've gotten the right software and implemented it appropriately with the appropriate partners. Melissa, do you want to talk a little bit more about the details around the Surescripts types of implementation that would permit this type of seamless workflow for providers?
Sure, absolutely. So through our implementation, as I had mentioned earlier, the eligibility and formulary data would be made available within the EHR. And by leveraging the formulary and coverage details that are specific to that patient's plan, Surescripts has access to all of these coverage details that are provided to us by our PBM partners. And of the PBM partners that we're working with, they fully expect to start sending coverage details in support of the electronic prior authorization process to make sure that, if a drug does in fact need a prior authorization, that information is flagged in the formulary file. Now, the EHR would reference that information, and if they are alerted that a prior authorization is needed, what would then happen is that they send one of the first transactions that make up the EPA standard, which is called the EPA initiation request. And that is really the first transaction that's part of the EPA standard that's sent from the EHR to the PBM. And through that, they ask, does this patient for this drug need a prior authorization? And if they do, the PBM will respond back with information indicating that they do, and the set of questions that need to be answered. And if in the case where perhaps maybe the prior authorization, the formulary file indicated that a PA was needed, but for that particular patient, maybe they already have a PA in place, or maybe that coverage rule doesn't necessarily apply to that specific patient, the PBM would then return information back to the EHR indicating that no, this patient actually does not need a prior authorization, and the set of questions would not be supplied. So it really provides the opportunity to know up front, if in fact a prior authorization for that patient, for that drug needs to be addressed. So,
Melissa, a clarifying question then that just came through. Is implementation of the formulary and benefits segment of script 10.6 a requirement before being able to implement the e-prior authorization standard?
Well, I should clarify that the eligibility is a X12 271 transaction, and then the formulary transactions would be leveraging the formulary and benefits standard. And from an industry-wide perspective, everyone needs to be moving to formulary and benefit 3.0 to meet the CMS mandates, but that's not currently a prerequisite to do EPA. And then the other thing I just want to clarify is that because the EPA messages are part of a new script standard, that's under a new version of the script standard. The EPA messages are not part of script 10.6. And then the other thing I just want to clarify as well is that if a customer is on script 10.6 and they want to do EPA, we wouldn't require them to move to the next version of script to support routing. They would just need to support the EPA messages under the current version of the NCPDP standard. And then one thing I just want to also clarify is that for our implementation, EPA does require the use of eligibility and formulary for EPA because it's critical to the it's critical to the support of the prospective EPA implementation.
And that makes a lot of sense. Then with our final question, and I was so excited that this one came through, who should software vendors contact for technical requirements and more information that's been presented today? Where can they start? Well, you can always reach out to NCPDP because they have the NCPDP implementation guide, so that's always a great place to get started. And I believe that link is provided in our webinar for folks that aren't interested, but you can always go to www.ncpdp.org and get started from there. And then you can always go to the Surescripts website as well, and we would be more than happy to talk to anyone that's interested in engaging with us for an EPA implementation. Excellent. I just wanted to give each of you an opportunity to provide us with any closing remarks before I go through a few housekeeping items. So, Melissa, did you want to start?
I really don't have
closing
anything.
Thoughts?
No, I think this was a great discussion today. I'm really excited to be part of something that's really going to make a difference in healthcare. And I just am really grateful for giving myself and Surescripts the opportunity to present today. Thank you.
Excellent. And Dr. Mirko?
And I guess I'll have the last word. I will, I think, close in the way that I started, that this is a very, very exciting place for us to be with healthcare. And I think that the new transparency that's going to come about in implementing the EPA standard is really going to revolutionize a lot of the interactions that we have with payers and with patients, and that will push us to a more patient-centered way to deliver care, specifically to prescribe and dispense medication.
Excellent. Thank you. And I did want to share one housekeeping item with our audience, so if we can advance the slides, please. So sliding and recording information for today's town hall, as well as our previous 2 town halls on e-prescribing and medication history, are available on the HIMSS website at www.hims.org/library/pharmacy-informatics. I know that's a bit of a mouthful, so you can go to www.hims.org and just type into our Google search pharmacy informatics, and that will pop up. With that, I want to thank Surescripts again for sponsoring the Pharmacy Town Hall series. I want to thank NCPDP for serving as a collaborator, and a big thank you to Melissa Brown and Dr. Anita Mirko for speaking today. With that, we are ended today's presentation. Thank you.